Chandrasekar, and he'll be talking on palpatory methods of abdomen and the clinical science. Professor Chandrasekar.
Yes, yes, sir. Thank you, sir. Thank you very much for having me in a technology-driven era. Like the art of medicine is slowly coming down, and it's right time that we need to teach the youngsters and younger colleagues the art of medicine. So medicine is always learned at the bedside, not through the gadgets. So I think you have taken a very big initiative to teach the younger graduates and younger colleagues on the importance of the bedside medicine. Today, I think my slides are visible, sir. Hello.
Yes, yes, but
Yeah,
I think it's not in slideshow view.
Yeah, 1 minute, madam. Yeah. Yeah, 1 minute. It's not coming, madam.
No, it's not in slideshow view. I think it's going little outside the screen.
Oh, okay. Yeah, 1 minute.
That format is not there here.
Yeah, 1 minute. Yeah.
I think you can click that slideshow on top, no?
Yeah, I did that, but it's not coming. Yeah.
Okay, it's okay. Then you present like this. What is that?
Yeah, okay. I think we have a very important thing, that is as far as the abdomen examination is concerned. The liver and spleen examination is the most important thing. Like every day, like we do see number of conditions that can cause liver and splenic enlargement. In the next 12 to 15 minutes, I'm going to talk to you about the very important and salient aspects of how we can palpate the liver and spleen. So before that, we should know little bit about the liver anatomy. Like a liver is the largest organ which weighs which accounts for 2 to 3% of the total body weight. And we all know that it has got a right and left lobe, and the right lobe, we have a radial lobe, the extension, also tongue-like projection. It is situated in the right hypochondrium, and the normal span is 12 to 15 centimeter. And it does have a dual blood supply from hepatic artery and portal vein. So the palpation of the liver is what it can be palpated by 5 different methods. It's very simple only. So it's 5 different methods, very simple things. I'll show you one by one. The conventional and traditional method is what we do is we need to do certain things before do any clinical examination. We need to wash our hand, and we need to introduce ourselves to the patients and explain the procedure and what we are going to do, and position the patients and come to the right side of the patient and respect the dignity of the patient. Sometimes the abdomen examination kind of thing, when we expose the abdomen part of it, better to, particularly a female patient, better to keep a female attender or nurse or a female doctors by the side of the examination. So that is more important. And the clinical examination of the liver, it starts with the just introducing and explain the procedure and make the patient to flex the knee so that you don't exert much tension in the abdomen. So we need to place the right hand. We need to come to the right side of the patient, and we need to place the right hand on the right iliac fossa that is parallel to the costal margin, and keep the hand steady during the inspiration and feel for the edge, liver edge, as it descends down with each inspiration. Suppose if the edge is not felt, we need to move the hand upwards towards the costal margin by 1 centimeter during the expiration. So this is a very simple thing. So this has to be repeated until the liver border is felt. So this is what we need to do. And this is the thing. Young doctor, you starts from the flexed knee, he starts from the right iliac fossa, and he gradually keep the hand parallel to the palpating organ or to the costal margin. He gradually ascends the hand, the examination hand, till he gets the palpability of the liver border. So that's a very simple thing, what we have been using it, the conventional method, what we have been doing it. So there are certain other methods also, which I will tell you. So this is the other method. So it's called the preferred method. So what we need to do is the thing is like we need to um, come to the right side of the patient, sit by the side of the patient. Okay, so that is more important. And what we need to do is we need to place both the finger just below the costal margin, and the fingertip should face the patient. So we need to apply gentle pressure to feel the palpability of the liver or the resistance which we could feel. So that will give you some kind of idea. And if there is a resistance is felt, we need to examine this patient by this method from above downwards. So we need to come slowly 1 centimeter below with each inspiration down. So this is another preferred method. So there is an alternate method. So that is a very, again, a very simple method. So that's a very alternative method. So we need to come to the right side of the patient and we need to place the right hand just below the right costal margin, and we need to gently insinuate our finger and look for the palpability of the organ or whether any resistance is felt or not. So this is the third method which we need to do. Suppose if there is a resistance is felt, as I already alluded in the second method, the preferred method, we need to come little 1 centimeter below till the resistance disappears. So that denotes the lower border of the liver. Next method is the hooking method. What we are supposed to is we need to go behind the patient. We need to face the foot end of the patient and we need to use both the hands and gently insinuate under the right subcostal margin. So that's called a hooking method. In case if your patient is you're having a uh, liver is big enough, like it will be palpated by the traditional method and by the preferred method. Suppose if it is very small, and sometimes if we expect a liver to be enlarged, in that case, like we can go just to begin and do this gentle insinuation and ask the patient to do a slow, deep breath, and you need to hook the curl our fingers inside the subcostal margin, and we need to look for the palpability of the organ. So that we call it as a hooking method. The final thing is like what we do in, I think most of you know that, like it's called a dipping method, particularly in cases where there is a fluid, a huge abdomen distension is there, and there is a fluid collection is there. So again, we need to start from the right iliac fossa, and we need to keep one hand over the another, and we need to gradually ascend up. And before that, like with each inspiration, we need to suddenly make a downward shift so as to displace the fluid inside and to look for the palpability of the organ. So this is a very essential method which we do both for liver and spleen in case of ascites. In intense ascites, still it's becoming difficult, but in mild to moderate ascites or a huge obese belly, like where we can use this dipping method as one of the method to look for the palpability of the liver. So whenever we look for the liver, there are certain things which we should look for. The liver, we should look for the consistency, whether it is soft, firm, or hard. We should look for some nodularity. So in cirrhosis, we can have a nodule, and as well as in malignancy also, we can have the nodule, whether it is tender or not. The borders are sharp or rounded. So these are all some of the things which we should make. The another thing, as far as the liver is concerned, we should also check for the liver span. It's again very simple. Like what we are supposed to is like we need to percuss from the in the anterior part of the chest, in the mid-clavicular line, from the fourth intercostal space. Usually the liver dullness starts from the fifth intercostal space. When you go down, percuss down, like you may get a dull note. So that begins, you need to mark that area. That is the upper border of the liver dullness. Then you need to come down to the right iliac fossa. Either you can palpate or you can percuss, and you need to gradually ascend up with each expiration and look for the dullness or the palpability of the organ. So that denotes the lower border of the liver. So normally the liver span is around 12 to 15 centimeter, and in younger individuals it is usually around 10 to 12 centimeter. So that one has to remember. So the liver span is also very much important. But we should not forget certain conditions where the liver is not enlarged, but still it can be palpable, like a patient with emphysema or patient with asthma or patient with or patients with any subphrenic collection of fluid or even a massive pleural effusion, the liver still can be palpable. So one has to ascertain the cause for the hepatomegaly based on the other clinical finding. So this is very important. There are 5 methods. One is traditional method, preferred method, alternative method, hooking method, and dipping method. Dipping method in ascites, traditional method is the usual thing which we do. The other 3 methods, when we are getting a very small sized liver, like where we can look for, we can do the other methods to look for the palpability of the organ. So next we move on to the spleen. So as we all know, like a spleen is an intraperitoneal organ located in the left hypochondrial region, and it is surrounded by various organs like and viscera. It is connected to the stomach by the gastrosplenic ligament, and kidney by the renal ligament, and usually it's not palpable. So if it is palpated means like it has to enlarge at least 2 to 3 times its size. So the spleen also usually enlarges towards the right iliac fossa. That's why for splenic enlargement also we need to begin the examination from the right iliac fossa. That is due to the presence of phrenicocholic and the lieno-renal ligament. So these two things prevents the descent of the spleen directly from the left hypochondrial region to the left iliac fossa. So it enlarges towards the right iliac fossa. That's why we need to start the examination from the right iliac fossa for the spleen. So this is again, it shows the picture shows we need to start from the right iliac fossa, and what we need to do is like we have to keep the hand firmly on the surface of the abdomen, not the finger. Like we should not poke our finger. We need to keep the palm, the surface of the on the surface of the abdominal wall, and we need to keep moving this hand with each inspiration, and we should look for the palpability of the splenic edge as it descends with each inspiration. Suppose if the thing is not felt, we can move the hand diagonally from right iliac fossa to the left hypochondrium by 1 centimeter during the expiration. So when we are close to the, suppose if you hit some splenic structure or resistance is felt, even we can use the tip of the fingers to can be used to feel the splenic tip. So this is what you could see in this picture, like where this gentleman, he started from the right iliac fossa. The hand is kept firmly, the entire surface, not poking. Okay, entire surface is kept over the abdomen, and we should start feeling that. So many times, like many students, they start examining from the umbilicus onwards. So this should not be done. Sometimes the massive splenomegaly can also be missed. So that's why the conventional teaching is to start from the right iliac fossa. So not only that, there are other methods to palpate the spleen. The same situation, if the spleen is mild, suppose still if you want to demonstrate the spleen, what we can keep do is like we can apply a gentle pressure on the lower posterolateral aspect of the left rib cage by using our left hand. So we need to apply some gentle pressure, and again using our right hand, we should look for the palpability of the organ. So this is called a bimanual palpation. There is yet another method that is called hooking method, similar to the hooking method which we have seen already with liver palpation. You need to come to the left side of the patient, and we need to gently insinuate our finger under the subcostal margin and look for the palpability of the spleen. There is one more method that is called a Middleton's maneuver. So it's a combination of bimanual palpation and a hooking method. So again, we need to come to the left side of the patient facing the foot end of the bed, and we need to use the hooked finger on the left hand, which is placed under the costal margin, and with the right hand we need to exert gentle pressure over the posterolateral aspect of the left lower thorax. So this is called Middleton's maneuver, and the patient is asked to take a deep breath, and the spleen is felt at the end of deep inspiration if it is enlarged. So this is what you see, like this is the Middleton's maneuver, what this doctor applies the pressure on the using his right hand on the posterolateral aspect and he, at the same time, using his left hand, he gently insinuate his finger under the subcostal margin and look for the palpability of the spleen. There is another method which I already told you, the dipping method. This is something similar to the dipping method, which we have seen it with liver enlargement. So not only palpation, but sometimes splenic percussion also can give us some clue regarding the enlargement of the spleen. So there is another method called the Cassell's method, where the patient is made to lie supine, and we need to percuss in the lower intercostal space, particularly in the anterior axillary line between 8th and 9th rib, and usually it produces a resonant note if the spleen is normal in size. So if you perceive a dull note, dull percussion note during the full inspiration, it usually suggests splenomegaly. And this is one of the most sensitive method with 82% sensitivity and 83% specificity also. So this is what you see, the percussion on the along the anterior axillary line on the 8th and between the 8th and 9th rib. If you get a dullness means like that is indicates that the patient has got a splenic enlargement. Sometimes we may not be able to palpate by the palpatory method. In such cases, you can resort to the percussion method also. So this is, we know that like a spleen has to enlarge at least 2 to 3 times, even if it is enlarged minimally. So this is a method which can help us to find out the splenic enlargement. The last method is, which I am going to say is the Nixon method. So where again, the patient is placed on the right side so that the spleen lies above the colon and stomach. The percussion, we need to do the percussion at the lower level of the pulmonary resonance in the posterior axillary line. Yes, whereas in the Cassell's method, the patient is placed supine and we need to percuss on the anterior axillary line. In the Nixon method, the patient is put on the right lateral position and we need to take the posterior axillary line. Cassell's anterior axillary line, whereas Nixon it's posterior axillary line, and we need to proceed little bit diagonally along the perpendicular line towards the lower mid anterior costal margin. So the usually we get a dullness. So that is because of the spleen. Okay, it measures around 6 to 8 centimeter. Suppose if the dullness is greater than 8 centimeter in an adult, it is assumed to indicate a splenic enlargement. So this is what the picture you see here. The patient is put on the right lateral side, and from the posterior axillary line towards the mid-costal line, like we need to percuss, and the total area of dullness we need to measure, this diagonal measurement which we need to do, and if it is more than 8, it indicates the enlargement of the spleen. So as with the liver enlargement, again in spleen, we should look for the consistency, whether it's a soft spleen, firm spleen, or a hard spleen. And we should also look for the notch and the tenderness. So these are all some of the things. So there are many classifications with related to the spleen, mild, moderate, and massive splenomegaly. I'm not, going to dwell on those part of it. My concern is only to teach you about the basics of liver and splenic examination in a clinical, examination part of it. So we have learned the liver palpation by 5 different methods and splenic palpation by 3 methods. And of course, by percussion, we got Cassell's and Nixon method, which can enable us to find out the splenic enlargement. So I think with this, I thank again Dr. Palni for having me here. And if there is any kind of discussion, I'll take it up a little bit later. Thank you, sir.
Thank you, Professor Dr. Chandrasekar. That was a wonderful clinical demonstration as well as all the science which is important from postgraduate's examination point of view. Thanks once again. I invite Dr. Batma Lakshmi, consultant ophthalmologist Sankar Nethralaya, to give a talk on testing the acuity of visual field of color vision.